Good morning, everybody. This is Kevin Hsueh, one of the presenters for the MASIC case conferences. We're just getting started. I was reminded by our MHA colleagues that if anybody has multiple people listening in on one line, if they could just send an email over to Megan Griffith, just reminding her, saying who's attending. That is very helpful for our records. I'm going to give people just like 2 or 3 minutes just to get started. So this is the third MASEC case conference, the second since we restarted earlier this spring. So today we're going to give a couple of updates on the MASEC program, particularly regarding the webinars and the case conferences. Oops, this is not quite updated. We have 3 case conferences today, and two of the 3 are drawn from our MASEC members. So these are cases you wanted to discuss. So a couple of disclosures. This webinar is supported by the Missouri Department of Health and Senior Services with help from a Centers from Disease Control and Prevention grant. And I'm a collaborator on an investigator-initiated study of candidal infections funded by Astellas Pharmaceuticals. These are interactive sessions. So we use 2 systems. One is the Poll Everywhere system so that people can post questions. Let's see. If people could log on to Poll Everywhere /MASEC and confirm that the system's working for you. The other system that we use is the GoToWebinar hands up system. So please, if you have any questions during the entire conference and you want to voice it over the phone, please just raise your hand. Everyone starts on mute, but once I know that somebody has raised their hands, I can selectively unmute them. So that will help. It keeps phone clutter and the feedback to a minimum. So when anybody raises their hands, we'll unmute them so they can ask their question or post their comment. So I'm going to give everybody a couple of seconds just to log on to the Poll Everywhere software. It shouldn't require any passwords or anything like that. It just requires you to put in a login or user screen name. A reminder, the responses to the surveys and polls, just like the webinars themselves, are recorded and used to generate and improve future webinar content. This was actually incredibly helpful during the last case conference because we pulled many of these cases specifically from those questions. So I'm going to give people a couple of seconds. Excellent, and we continue to gather some attendees. All right. And people can continue to log in to Poll Everywhere while we get started describing the cases. If anybody has any issues, just raise your hands and we can try to work through those as well. Okay. Today's panelists, it's myself, Michael Durkin, and Erin Rackmiel, as before. So there's a couple of webinar scheduling updates. One is that our presentation on the NHSN antimicrobial use and resistance module will be happening on May 17th, so that's next month. We also have a resource limited settings presentation tentatively scheduled for sometime in June. You'll hear about exactly when that is a little bit later. And then an antibiotic allergies and antimicrobial stewardship lecture on July 12th. All right, so let's get started with the first case. So this was actually, this case was brought to you by one of your fellow MASEC members. In this case, it was a 70-year-old man with a history of diabetes, schizophrenia, and Alzheimer's disease. He does get straight cath 3 times a day because of urinary retention. He was admitted to the emergency room with fevers, diarrhea, and fatigue for about 10 days. He has a history of a family member recently positive for influenza A. On admission, he was afebrile. His white blood cell count was 4.4. He had a normal creatinine, a respiratory viral panel that was negative, and his urine was cloudy, and a culture was done. He was started empirically on IV ceftriaxone at 1 gram Q24 hours. His urine culture came back with enterococcus fecalis. It was sensitive to ampicillin, ciprofloxacin, doxycycline, nitrofurantoin, and vancomycin. The treating physician was alerted to bug-drug mismatch and wanted to switch to meropenem. And the antibiogram for the hospital indicates a 98% sensitivity of enterococcus fecalis to ampicillin. Looking at what people have picked out in terms of stewardship issues, so meropenem is too broad, and I would agree with that generally. A cloudy urine is not an indication for culture. This is surprisingly, even very, very experienced providers seem to make this mistake all the time, that urine character is not necessarily a good indication for culture. The rest of my colleagues, what kind of issues do you guys have from this case? And we'll pull up the sort of framework just so that everybody has a structure to work off of.
Yeah.
Kevin, I see that somebody's got their hand raised. Do you want to go to them first, or do you want us to discuss it?
Oh, no, let's go to them first. Hold on one sec. I am unmuting John Brown. Oops, nope, disappeared. Oh. John, if you want to talk, raise your hand, but I'm not going to do it right now. For some reason, it didn't show up. Sorry about that. Oh.
Kevin, you want Aaron and I to chime in now?
Yes, please.
Aaron, do you want to start, or do you want me to start?
You can go ahead and start.
Okay. One thing that was mentioned in the history, too, is that he had diarrhea. We don't have a lot of information now, but my guess is with this person having so many comorbidities and being straight cath, he probably has a history of significant antibiotic exposure, too. C. diff would be on my list of potential things that could be causing this, too. And then, I don't know about at your institution, we oftentimes have issues obtaining flu tests. It sounds like there's a pretty good one here with the respiratory viral PCR that was negative, but at some institutions, a screening test, especially at outside places or urgent care facilities, can be a rapid flu antigen test, which isn't very helpful. The flu PCRs are really sensitive and specific if they are obtained properly. One of the issues we have at our facility, too, is that some of the newer staff don't actually obtain specimens in the appropriate way. When you're getting a respiratory viral swab, you really want to go pretty far back. It should be uncomfortable for the patient. So if you had a very strong clinical suspicion for influenza and the test is negative, you might want to talk to the clinician about how the test was obtained, or if they think the test is accurate. We do have somewhere when we have a strong suspicion and the test is negative, we'll repeat it if we think the specimen collection wasn't ideal. So those are things that kind of come to mind. In my opinion, the diarrhea in particular, I think the other comments that other people left about UTI thoughts are very timely and pertinent. Enterococcus can cause UTIs. We frequently see it as a colonizer too for patients as well. So there's new guidelines by the IDSA about asymptomatic bacteria, and they mention if people have altered mental status, in particular, that you should look for other factors that are causing their delirium before you attribute it to a UTI. And I think that's similar for cloudy urine or foul-smelling urine, that really those aren't very sensitive or specific for picking up urinary tract infection. So I might treat this as a UTI if we can't come up with anything else, but I think that there's probably more stones that need to be turned over first.
Right. The unfortunate thing is
definitively state that the patient has a UTI. It's okay to treat them empirically while you're sorting some of this out. The only harm that they get is if they have C. diff and we're not picking that up quickly, and we might be adding fuel to the fire by giving them antibiotics. So those are kind of my thoughts.
I mean, IV ceftriaxone is a great empiric agent. It's broad, but not too broad. It gets very good coverage for many of the common community-acquired infections. So if you're starting off and you don't really know what's going on, it's not a bad drug. It won't touch Enterococcus faecalis because the enterococci are intrinsically resistant to cephalosporins. I would reinforce that, unfortunately, especially family members, urine character is one of the few things that they can actually see. And so oftentimes it's fixated upon, oh, it's dark, it was foul smelling. But that's not usually, that's usually just an indication of whether or not somebody's dehydrated or volume depleted. It's not a urine microscopy is the thing. Erin, you had something that you wanted to bring up?
I was just going to say that, thinking about the approach to the physician, because I'm always thinking about how you're making these interventions and how they're received and what we can do to maximize that. And so I would be curious, and probably just asking the physician, well, why do you want meropenem as opposed to ampicillin or nitrofurantoin or something like that? And making sure that they're aware of the antibiogram, because sometimes they're not, especially, if there's somebody who's working at multiple institutions or, is new to your facility. So making sure they have all of the data, because sometimes in the pharmacy we just assume that they've got all the same information that we have, and they might not.
Right.
So that's another thing I would bring up.
Right. Especially in the ED, it's not infrequent that you have moonlighters or people who are not familiar with the patient population or any of the hospital specifications. So generally, just looking at the agents that we're talking about, so ampicillin gets very well into the urine. Ciprofloxacin, of course, does as well. Nitrofurantoin gets very well into the urine, though not particularly well into the kidney parenchyma. Vancomycin gets in pretty much everywhere. Doxycycline is one of those that it's interesting that that was brought up in a urine culture. It's not usually a urinary active agent, just because it doesn't get excreted very well. I think it's like 20% or something.
Yeah, Kevin, you're right. It's about 20%. It's pretty low overall.
Did any of the? I'm going to flip back to our member comments to see if anybody else had any other stewardship issues. So I think, if I remember right, that the big question was, why couldn't this person be converted to ampicillin or even an oral agent if they were really thinking that this is a urinary tract infection? And I agree with Erin. While it's sometimes very gratifying for people, for physicians to feel like they, have a full understanding of everything. Physicians are human, and they often just forget, forget that there are nuances to certain things. Meropenem could just be the first drug that came to mind in terms of an IV agent. Just reminding them, and usually it's not malicious in any way. It's just they probably weren't considering all the details. In particular, I'm not sure, a lot of physicians don't think VRE and don't even think that penicillins will work against these kinds of organisms. So a couple of key points that when I was going through this case, I picked out. So we had already talked to many of them. Nitrofurantoin is usually very highly active against enterococcal UTIs. So if this was a simple urinary tract infection, that's a great agent. I agree with Aaron. Initial gentle reminders are probably going to be most effective in this case, because it sounds like it may just have been insufficient knowledge that was the issue here. For an uncomplicated urinary tract infection, if this really is that, initial stabilization with IV agents is pretty reasonable, but you can pretty rapidly oral convert, especially if the person's mental status or other systemic signs improve very quickly. So discharging the patient after 3 to 5 days in an uncomplicated urinary tract infection seems to be pretty reasonable now. Usually more people choose 7 to 14 days, especially in a case like this where the person has urinary retention issues. That's perfectly reasonable. There are a couple of things I wanted to bring out, which is the antibiogram is not a perfect representation of every bacterium in your hospital. Antibiograms are generally built from what they call first isolate per person. So when a person comes into the hospital, the first isolate, the resistance characteristics for that isolate are used to build antibiograms going into the future. So this means that for patients who are here for a long time, for in the hospital for a decent amount of time, say in the ICU where they're critically ill and are developing resistance or acquiring resistant bacteria in the hospital, antibiograms aren't necessarily quite as representative of those patients. But for a patient like this who came in with the bacteria, this is actually pretty well matched to this type of patient. So I think for this kind of patient, it's pretty trustworthy. And then we already talked about the urine characteristics. I would say there's one other thing, which is that if we look back, so the urine culture included doxycycline. There are some hospitals that have urinary panels of antibiotics that they report just for urine cultures that eliminate some of these drugs that really aren't active in the urine, so that providers choose or aren't as likely to choose those. And in some studies, they have been shown to be relatively effective. It's basically limiting results, at least on the surface, so that people don't misorder. So I wanted to do some follow-up on case one. So the stewardship pharmacist at that institution introduced themselves as a physician and just presented some information on stewardship. And it sounds like probably a very gentle encouragement to switch to a more narrow spectrum agent. And then the physician switched the patient to ampicillin even before the sensitivities were back. So that was a great win on that part. The enterococcus fecalis culture came back. Oops, I think I forgot to censor some of this out. Ampicillin, ciprofloxacin, doxycycline, linezolid, nitrofurantoin, and vancomycin. And then eventually the patient was switched to oral amoxicillin 875 BID for 10 days for the continuation of therapy. Now, for enterococcal UTIs, amoxicillin is a well-established and accepted agent. But I did want to bring up one point. So before that, I wanted to poll the audience. So how frequently do people see ampicillin-sensitive enterococcus fecalis treated with other agents such as vancomycin, linezolid, daptomycin, doxycycline, instead of ampicillin, amoxicillin, or another beta-lactam? So I'm seeing a lot, or right now, a lot of most of the time, sometimes. This is a common mistake that I think we see a lot in the hospital, is that people are so used to considering enterococcus to be a very resistant organism that when it is beta-lactam sensitive, I think many providers are very suspicious of whether or not they can actually use a narrow spectrum agent like ampicillin or amoxicillin against an organism that they're constantly reminded it can be very resistant. So I agree. This is a pretty frequent occurrence in our institution, and something that we have to keep reminding people that they don't have to use vancomycin. The unfortunate thing is that impulse to use vancomycin against enterococcus, I think, is one of the reasons why we see so much VRE nowadays, at least in larger institutions. I'll give people another
Kevin,
second.
this is Mike. I guess I have one other comment or question, I guess, for you and Aaron that might be worthwhile to bring up and maybe get your insights on for the panel. Sometimes the susceptibility data will only have information on certain antibiotics, and in this case, there were susceptibility data on ampicillin, and we ended up recommending amoxicillin. What antibiotics do you usually feel comfortable with in terms of inferring susceptibility data on based on the susceptibility results that you obtain? So other situations where you'd feel comfortable using amoxicillin because it's ampicillin susceptible. Can you list a few other antibiotics or classes of antibiotics you feel comfortable doing that with?
Sure. Aaron, do you want to answer first, or do you want me to go on?
You can go ahead. You're probably
Sure.
a little more current on that.
So this is actually a really tricky question. So the usually with many organisms, you really can't always infer susceptibility based on a similar class or a similar beta-lactam. In the case of enterococcus, generally I'm comfortable with more broad spectrum beta-lactam. So unicin, clearly, because it's got ampicillin in it. Piperacillin tazobactam seems to be pretty reasonable. Augmentin, because it's got amoxicillin as a component. Clearly, the cephalosporins are out since enterococci are intrinsically resistant against the cephalosporins. But except for ertapenem, the carbapenems, meropenem, imipenem, I think doripenem, though we don't use it very much at our institution, have reasonable enterococcal coverage, and so I generally infer sensitivity against those other beta-lactams as long as the enterococcus is sensitive to ampicillin. Amoxicillin basically is essentially an ampicillin prodrug that is just absorbed better. So generally, you can infer amoxicillin sensitivity from ampicillin sensitivity.
That's great, Kevin. What about generalities? So not just enterococcus. If something's susceptible to cefazolin, for instance, would you feel comfortable using Keflex and other things like that too?
Generally, yes. If it's the same class of beta-lactam, and by class I mean if it's a first-generation cephalosporin, it's the same. It's another first-generation cephalosporin. But honestly, I don't think it's universal. There are a lot of nuances between these drugs, like cefepime and ceftazidime susceptibilities can't be inferred from one another. Even though they're somewhat similar agents. Same thing, ceftazidime and ceftriaxone. So I would warn against just intrinsically assuming sensitivity from between drugs, because it can lead to mistakes. At least I've seen that sometimes.
Yeah, I think there's probably a few rules of thumb that you can probably do. So ampicillin and amoxicillin, Keflex and cefazolin.
Yeah,
you're
and
right. With some of the higher generation cephalosporins, that's probably true. One thing that we oftentimes will see that's missed as well is that we'll see an organism susceptible to third generation cephalosporins, especially urinary pathogens, and then they'll end up, being admitted for IV antibiotics when the provider might not consider an oral third generation cephalosporin. Kevin's right, though, that a lot of these can sometimes need some more interpretation. So if you do have questions, or you think that, hey, maybe this isolate's susceptible to ceftriaxone, could we use an oral third generation cephalosporin like cefpodoxime? Instead, talking to the microbiology lab to see what their thoughts are can be very useful.
If people are interested in those kinds of general rules of thumb, we can try to put something together. It may not be quite as comprehensive as people would like. There aren't always rules of thumb for every single organism, or that prove true across different organisms, but there are a couple, and they can be very helpful when you're just trying to, encourage oral conversion. And if people want to, would you want to avoid nitrofurantoin due to the elderly patient? Oh, this is a good one, Mike. You do more research on nitrofurantoin than I do,
yeah.
So.
Sure, I can address that. So the American Geriatric Society actually releases a list called the BEERS, where they list which antibiotics or other medications should be avoided in elderly patients. They specifically address macrobid in there. Historically, people have recommended avoiding it if their creatinine clearance is less than 60. I think that's from the package insert in the studies that have been done. As of the last several years, the American Geriatric Society has revised their recommendations, so they feel comfortable prescribing it in patients with a creatinine clearance down to 30 now. So for this individual, a 70-year-old man, there's nothing specifically noted about impaired renal function. He probably has a clearance greater than 30, and it would work okay. I do have some colleagues that will actually use the lower creatinine clearance, use it in lower creatinine clearance as well, and they've had it work too. The concern is with lower creatinine clearance that you might not get the same urinary concentration, so your treatment failure rates might be higher. But that's a great question, and it's not very well known among most providers, including a lot of ID providers, that those creatinine clearance cutoffs have changed. So that's useful, and I think you can really convince physicians if you print out those American Geriatric Society recommendations. They're freely available online if you look them up, and they have it for all the medications. They don't have a lot for antibiotics that they specifically address, but macrobid is one of them.
One of the concerns with low creatinine clearance is buildup of the drug leading to an increased risk of interstitial pulmonary fibrosis, which I think is the big concern with the use of nitrofurantoin. But one thing to realize is the risk of that is vanishingly low. It's not even fractions of a single percent. So this is not a common occurrence, and I think initial concerns were probably overstated or over assumed, because it's really something that is seen incredibly infrequently.
Yeah, Kevin, you're right. They mentioned specifically that you should be worried about that for patients who would be using it chronically. So if you use it for suppression, for example, but for an acute use like this, it shouldn't be at the top of your mind when you're trying to decide whether or not to use this versus another agent. But we do avoid using it for long-term suppression whenever possible because we do think about the pulmonary fibrosis component.
So just to loop back to some research, there is one concern about the use of beta-lactams as a general rule in urinary tract infections. So for enterococcal urinary tract infections, amoxicillin or amoxicillin clavulanate are perfectly reasonable. But for other uropathogens, there has been some evidence from the last 2 decades which show that oral beta-lactams aren't the most optimal agents for the use of treating uncomplicated urinary tract infections. So there's a study, this is probably the most notable, from Houghton et al. In JAMA of 2005, which compared the efficacy of ciprofloxacin against amoxicillin clavulanate or Augmentin in the prevention of recurrent urinary tract infections. And what it really looked like was Augmentin wasn't great at treating both non-susceptible and susceptible uropathogens. As you notice, the lines sort of converge, which is kind of an odd phenomenon. But basically, you have to be the take-home point from this study isn't that you can't use oral beta-lactams against urinary tract infections, but that you have to be a little more careful. It may require a longer duration of therapy. You may need to do follow-up urine culture or urinalysis to make sure that you've actually eliminated the organism. Ciprofloxacin penetrates the urine very, very well, and there are many other agents, including macrobid, that do so. So I wouldn't take home from this that ciprofloxacin was necessarily the best agent. In fact, we have in Missouri generally, and definitely around the St. Louis metropolitan area, a very high percentage of ciprofloxacin resistance. So as an empiric therapy, it's not great anymore. You really would have to be using it judiciously. There are also, as I think everybody has seen, significant problems with the long-term side effects of fluoroquinolones, including increased risk of aortic aneurysm, of tendinopathy, and many other different side effects. So fluoroquinolones generally not the first agent of first choice nowadays, but just realize that with use of oral beta-lactams, you do have to be sort of somewhat careful that you've actually eliminated the organism. So at this point, I wanted to open up the floor for anybody to raise their hands or post on the on Poll Everywhere whether or not they had any volunteer cases to discuss. We built in some time this time around for people to present whatever interesting cases they've encountered or challenging cases. It doesn't have to be super complicated, but can be just anything with an issue to discuss. So I'm going to give people about 2 or 3 minutes. Doesn't have to be super well formed. And if people want to raise their hands instead of posting on the Poll Everywhere, I'm happy to unmute and then listen in. Opinions? Okay, so let's look at this question. Opinions on probiotics. If you've ever seen infection secondary to Saccharomyces, a patient with, it's hard to see. Sputum growing Saccharomyces cerevisiae, immunocompromised patient, status, so I'm assuming that's kidney transplant many years ago, in the ICU, greater than 1 month on the vent with pneumonia. Oh, this is actually good. So this is a contentious argument in medicine generally, but I think from infectious diseases standpoint, there are very, very few circumstances where there is data supporting the use of probiotics in that they have a benefit that outweighs their risks. At Barnes, because of the number of immunocompromised patients we see here occasionally, we have seen infections secondary to probiotics. And the biggest problem with probiotics is that you don't know what or how much you're getting. The variation in the amount of bacteria or yeast or whatever or living organism that's been packaged into those pills can be, from absolutely no living organisms, which isn't going to do anything good or bad, to, several log higher than they're supposed to be. And because of that, you can definitely have super infections with probiotic bacteria. They're not particularly virulent generally, but we've seen a couple, and they can actually be very difficult to treat, usually not because of the organism being very resistant, but more because those patients who get super infections from probiotics tend to be extraordinarily susceptible to any kind of insult and unable to protect themselves. Sputum growing Saccharomyces cerevisiae. So Saccharomyces cerevisiae is baker's yeast. It's the yeast used in beer and bread making. To have it grow in a kidney transplant or have it grow in somebody who's been on a vent for a while isn't actually that surprising, and that's because what you're probably seeing isn't an infection. That sputum culture is likely just the retained mucus that probably is providing growth medium for baker's yeast. It's an incredibly non-pathogenic organism. It can happen, but it's unlikely to have been the case in this circumstance. Generally yeast, except for very specific oddities or outliers, in pulmonary specimens is considered either a contaminant or a colonizer, not a pathogen. Let's look at this other question. When you discover that an antibiotic has been inappropriately started, is it better to discontinue, or why is this? Sorry, for some reason I'm having a hard time seeing complete the course. What do you guys think? What do you guys think about that question? I have my opinions, but I want to hear what the rest of the panelists think about that first.
Erin, what are your thoughts?
When it's been inappropriately started, I mean, if they're saying that they've ruled out an infectious cause for whatever reason they started it, then I would say stop it. I just lost my train of thought here because I was looking at my screen trying to move that panel out of the way so I could read.
I don't know why that's showing up there this time. Oh, there, it stopped. I don't know.
That's okay. Yeah, so, but if, the one thing I'm thinking of, which is a sort of a variant of this question, is when, an inappropriate antibiotic gets started and we don't get to intervene on it right away to make a recommendation to change it to something more appropriate. That's something that we deal with in the pharmacy all the time. And it is so much harder to come back on day 2 of therapy and try to convince them that they don't need this broad spectrum, that they could use something a little bit more narrow or direct, because the response you always get is, well, it's working. They're getting better, so I want to keep doing what I'm doing. So that's a challenge in pharmacy. So it's always better if you can make those interventions up front, which is not exactly this question, but that's something that I always would talk to our pharmacists about, was intervening at the first opportunity rather than waiting. But yeah, if you've ruled out an infectious cause, or you have an opportunity to narrow, I think that's generally the best thing to do.
Yeah, Aaron, I agree. I mean, we know that there's side effects with antibiotics, and a lot of physicians don't think about those side effects very much, but they're not benign drugs. So if we don't think that the antibiotic's providing any benefit and it's inappropriate, the only thing that it's really doing is providing the potential for harm for that patient. So when you're trying to weigh that risk-benefit calculation, if there's no benefit for the antibiotic, then there's only risk.
Right.
So I'd recommend stopping the antibiotic if you think it's inappropriate.
Right. The way that I look at it, it is a ticking clock. So we know from retrospective studies that every additional day on therapy, especially, I mean, if it's inappropriate, that includes inappropriate therapy, is an increased risk for Clostridium difficile, is an increased risk for the development of an antibiotic adverse event, whether that's vancomycin, renal toxicity, or the development of an allergy. I think what the poster is talking about is completing the course is something we sort of hammer into patients, that they have to finish their course of antibiotics because otherwise it's dangerous for them. That's if you actually have an infection. So if you have an infection that the antibiotic is treating, yes, you want to finish the course of antibiotic in order to make sure that there is not a residual amount of infection that either grow back or, even worse, has developed resistant or can grow back a resistant strain that is no longer susceptible to the antibiotic that you're talking about. But if you're especially not treating an infection or an infection that you think you are, all you're doing is supplying pressure on the other bacteria in that person, in particular their gut and their mucous membranes and everything like that, to become resistant. Those bacteria aren't going away. It's not like if you complete the course, you will, eliminate enough of those bacteria to prevent them from becoming resistant. They are going to become resistant because they're growing under the pressure of that antibiotic. So the faster you discontinue or switch to a more appropriate drug, the less likely you are to spur that development of resistance. That's my opinion. And I think there's more and more data suggesting that that generally is the way that the biology of resistance tends to work. It's a cumulative impact. But that's a really good question, whoever brought that up. We'll have a chance again later in the conference to volunteer cases or discussion questions. So please feel free to write them down and then post them when we get to it. Okay. I'm going to come back to this at the end of the conference, because I think those are going to be long-term discussions. Let's go on to case 2. So case 2 is a 67-year-old male with a history of hypertension, hyperlipidemia, benign prostatic hypertrophy, Parkinson's disease. He was referred to the hospital for the treatment of, and I quote, highly resistant UTI. That's what the referral paperwork says. The patient had 4 7 to 14-day courses of treatment for urinary tract infection in the last 3 months, including nitrofurantoin, Bactrim, cefodoxime, doxycycline. He had multiple urinalyses with greater than 50 white blood cells. All his urine cultures were growing E. coli, which was sensitive to nitrofurantoin, doxy, ceftriaxone, cefepime, meropenem, and resistant to ampicillin, cefazolin, and Bactrim. He's had for this entire time minimal symptoms, and the provider in the emergency room wanted to start IV cefepime. So, audience, what stewardship issues do you see here, if any? And please feel free to raise your hands as well. So let's see. Is this ASB? I'm assuming that means asymptomatic bacteriuria. That's a really good question, and I think that's literally the first thing that the consultants thought when they saw him is, he's not having, this is the thing that makes everybody concerned about that. Minimal symptoms. Remember that urinary tract infections are, they are clinical syndromes. And if you don't have symptoms, it's really hard, no matter what the lab results are, to meet the diagnostic criterion for a urinary tract infection. Why IV antibiotics? That's a good question. And for one of the things that I asked the attending when I started talking to him, do you really need to treat? That's a good question that goes along with asymptomatic bacteria. And does he have an indwelling cath or self-cath? No, he doesn't. He doesn't have an indwelling catheter or self-cath. And so I think the thing that was frightening people the most was this high grade or significant pyuria, the greater than 50 white blood cells that was just persistent. What prompted the urine culture? Initially, it was he was in the hospital for another reason. This was months ago. All of those things go along to ask the question, what exactly is going on here? So, panelists, let's talk about choice of agents. In particular, the fact that it's IV cefepime. Oftentimes, when we see providers want to use IV antibiotics for things that have really effective oral options, it's because they have a somewhat mistaken idea in their head that IV is always stronger and will be more likely to get rid of some infections. That's at least what I've seen quite a bit. What about you guys?
Yeah, I mean that's the justification that I think we hear a lot when we ask about that. So if you can point out the rates of excretion in urine of some of the oral antibiotics, then sometimes that's enough to change them. But yeah, I would question that IV use there for sure.
Yeah, and especially cefepime. I mean, even if you're thinking, okay, maybe maybe for some reason the oral antibiotics weren't getting very well into his urine. If he had renal dysfunction, which he didn't, maybe something like nitrofurantoin wasn't getting in very well. IV cefepime doesn't even make any sense because it's sensitive to ceftriaxone. You always want to use the most narrow spectrum agent. So that, even if you were encouraging them to just notch it down one step, that probably would be a bit of a win. IV cefepime is not any, for sensitive organisms, I don't think it's any better than ceftriaxone is.
Mm-hmm.
Yeah,
awesome.
Kevin, I would say that the other thing that comes to mind too, although this is a slightly different topic, with the urine cultures all grow in an organism with the same susceptibility, even if it's asymptomatic, I may wonder why they keep having the same organism present. It sounds like he has BPH and other factors too. I don't know if he's seen a urologist, but he may have stones or something as well that's contributing to persistent colonization as well.
Right.
Not that if they're asymptomatic, not that we treat them, but you might want to try to evaluate optimizing their urologic issues if they have any, or exploring if there's any underlying urologic problems.
Right.
Asymptomatic bacteria is common in older patients. It's less common in older men. So he may have a stone or something that's colonized with the same bug.
Right. It's this combination of pyuria and a consistent positive culture, I think, that would make us, at least from the infectious disease physician side, make us think, maybe there's something other than the classic urinary tract infection there. And honestly, I think that's generally the approach I would take with a physician in this circumstance, is really ask, what are they treating? Because this doesn't fit a simple urinary tract infection, right? None of this really fits. He got appropriate therapy for all of this. Granted, the Bactrim wasn't going to work. It was resistant, but mostly he got a relatively effective therapy. So why isn't it working? And I found that, when you bring up that question to providers, it does spur them to look at a broader range of diagnoses than oftentimes the patient came in with. This is the big problem, actually, in this case, I think, is that he was referred by a provider who said he had a urinary tract infection. And it's very easy for an emergency room doc or any medical, hospital medical provider to sort of anchor on what other people have told them and not really be thinking outside the box. So a couple of points. Nitrofurantoin is a great choice for a simple urinary tract infection, but we talked about its tissue penetration, which is poor. Mm-hmm. All the other selected agents have issues. Bactrim won't work. Cipro has lots of other side effects. Doxycycline won't even get into the urine particularly well. IV agents aren't particularly special. And this sort of fixation on a diagnosis that a patient comes in with is called anchoring bias. And that's basically that people hate thinking up new ideas, and so they'll sort of stick with what they've been told is the problem, even when when lots of different factors are saying it's not really what's going on. So I find asking probing questions about the diagnosis and treatment plan are very, very helpful. And then this is what I often say is that if treatment has been ineffective before, especially ineffective multiple times, it's often a signal that the diagnosis needs to be reconsidered. And this is usually pretty well received, I think, by providers, is that they realize, we're just trying to make sure that they're actually treating what they're thinking they're treating. This is wrong. So sorry about that. And then we talked about contextful drug sensitivities. Some labs do test urine cultures different than they test other things. So a follow-up for this case. So the ID physician was consulted. That was actually me. A digital rectal exam was done, which elicited prostatic tenderness and discharge. A culture of that discharge showed E. coli, the same E. coli that he'd had multiple times. He was diagnosed with chronic bacterial prostatitis, which is an infection of the prostate, but not of the rest of the urinary tract, and can be have very, very few symptoms. He was switched to doxy for 28 days. It gets very well into the prostate, though not into the urine. But he remained urine analysis and urine culture positive. He was referred to urology, and a prostate ultrasound was done showing prostate stones, and he's awaiting a TURP, actually, because it's likely that those prostate stones are carrying that bacteria, and it's not going away because it's stuck to the surface of a mineral, basically. So questions on this case for the audience? Anybody? You can raise your hands as well. So while people are putting those together, I'm going to skip to the teaching. Sorry, hold on a sec. We're going to do this case in the future, I think, because we just are out of time for more than 2 cases today. So any questions on this case? Questions or comments?
I'll just add, while we're waiting for a couple seconds here, that as a stewardship pharmacist, depending on your institution and how your program is set up and sort of how visible you are and how connected to ID that you're seen, in this case, if you're a smaller program and you're maybe not as connected to ID, at least not in the eyes of the providers at the hospital, I would say a first win is just getting that IV cefepime changed to something else. Like Kevin said, getting it changed to the ceftriaxone would be a small first win. If you could get them changed to the, something oral, the nitrofurantoin at the beginning. And then planting that seed, like why have they had so many UTIs? Has anybody thought about that? Because, when Kevin, as an ID physician, makes that recommendation to consider other diagnoses, sometimes that's going to be received different by the physicians than it will from the stewardship pharmacist. But you can still plant that seed. Then they may end up thinking about it later on their own, or they may end up getting another consult or something. But the response to a physician saying, reconsider the diagnosis, to a pharmacist saying, reconsider the diagnosis, is sometimes different. But don't be afraid to plant that seed in a case like this, I guess would be my comment.
Generally, even other physicians are not particularly receptive to, please reconsider the diagnosis. It wasn't framed that way. It was really,
right.
He's been treated before, it didn't work. I'm not sure, what makes us think that IV antibiotics are going to work when orals that are very effective didn't? And what can we do to sort of plan out how to approach this? Now, in this case, they changed the diagnosis completely. Sometimes you can just say, okay, how are you going to make sure that this actually worked? And then what are you guys going to do after it's, if it doesn't? And that way you sort of, you're kicking the can down the road a little bit by just, they may want to try IV antibiotics this time, but at least you're getting them to think more about what they're going to do in the future, as opposed to, let's just treat it again.
Yeah, I think it's just important to recognize that there are kind of small steps to winning these things, and there's multiple things that could be considered a win, and I like the idea of sort of planting that seed and thinking about how they would approach this in the future, or if the patient comes back again.
Right. Little steps, absolutely. Okay. What I'm going to do is we will skip towards, we're going to skip to the next case. I think we only really do have time for two. We'll bring that case up in the next conference. If people could leave feedback, our next case conference is actually pretty short from now. It's April 26th. I won't be leading that one. Mike Durkin and Aaron are going to be leading it. I'm off at the spring meeting of the Society of Hospital Epidemiologists of America. But if you have additional cases that you're interested in, either send them to the Missouri Stewardship or the Mo Stewardship at worcester.edu email, or leave them on the feedback form, and we've been responding to those as well. We heard loud and clear that people are very interested in vancomycin therapy and all the current discussions around vancomycin therapy. We are just trying to compile a lecture that does the topic justice. It is a complicated topic, and I don't think that there are any clear solutions at the moment. So what we're trying to do is actually put together the data so that people can at least understand the debate and the discussion. Of course, if there are things that we could do better, please leave them on the conference feedback. Hopefully this conference series continues to be useful. If people, as people brought up, if people are interested in sort of those rules of thumb for antimicrobial susceptibility interpretation, we would be happy to try to put something together. So it's, I think it's been great, and we'll see you guys on April 26th. Hope everybody had a useful discussion. Thanks, everybody. Signing off.
Bye. Thank you.